Good evening, sir.
Good evening. Good evening.
Yeah. Okay. मैडम ज्वाइन थे आज ने तनु मैम.
चेतन
Yeah. Hey, Dr. Sanjay, can you call Dr. Tanu मैम please?
एक मिनट.
मैं 21 मिनट में ज्वाइन करता हूँ वापस.
जो कर रहे हो बोलिए सर. तो पॉजिटिव सिंपल ये बाहर वाला निकल जाए.
Chetan. Chetan.
Yes, sir.
Srinivasan sir ने कहीं joint link problem था ये. Can you help him?
I think Tanu, I'm also having the same problem.
Yeah, I am joined through my phone, but I can't join through my laptop. I don't know what's the problem.
I think sir is also Dr. Srinivasan sir.
Okay, because I have shared the same link to everyone. Dr. Bhaskar has also joined.
So probably they are finding some difficulty.
Initially, there is a problem. Chetan, it is not joining directly. 2, 3 screens are opening, and after finishing,
Okay. I think now Bhaskar is there.
Namaste, sir. Namaste.
What is
Namaste,
happening,
namaste.
Dr. Gorpade?
yeah,
Hello,
namaste.
Dr. Tanu. How are you?
No,
Hello.
just a minute. There is a problem. I can't join from my laptop. Just a minute, please.
Okay.
No.
Shall I send you
No.
the link on email? Something like that? Yeah, now you
Now
can
I
join.
can join.
Yeah. Okay.
Dr. Tanu, we have
Maybe
sufficient
what
time.
happened, my connection got lost for a moment. That may be the reason.
Now
I don't know.
But I didn't have any problem.
That's what, yeah.
Actually, I also didn't find any problem.
I don't know why it's saying now it can't detect my camera zoom.
Madam, you are joined through your laptop or
Yes.
on mobile.
No, I have to join through my laptop because the problem is if through my phone I can't share my screen.
Yeah, वो difficult होता है. It's
No, take your time, madam. No.
Yeah, madam, sufficient time है.
नहीं वो ठीक है but अगर मैं कोई बात नहीं अगर कैमरा नहीं वर्क करेगा it's okay. Let me just share my screen and see I'm able to share my screen. But ये कैमरा नहीं काम कर रहा.
But at least I want to see the facial expression of madam.
So that you get a clue
to my responses.
I don't know why my camera is not working.
Yeah, it happens. In my laptop also once during the PG, somebody said that you are not seen. I said okay, but at least I have heard.
एक बार शेयर करके देखो ना आप स्क्रीन शेयर पहले होता है कि नहीं
हो रहा है
देख लो ना
हो रहा है share screen.
नहीं we are not able to see the screen.
Yeah, I'll just share it 1 minute.
Chetan, can
Yeah.
she totally log out and rejoin?
Yeah, I
That's
think
what she
madam,
has to do.
madam,
Thank
better
you.
to do that thing. Yeah.
मैडम लॉग आउट करके हो जाओ.
Log out and rejoin now.
Yeah.
चेतन
बस वही कि आप ये बंद ना करो लगातार चलता
email recently updated link.
खाना भी एकदम ready.
वो कॉपी पेस्ट करके उन्होंने
ये
Can you see my screen?
Yeah.
Screen is seen. Screen is
लॉग
seen.
इन किया है ओके
और अच्छे से तो इसको मेरा भी
now only thing is her video is not on.
So shall I log off and try again?
Yeah. Better,
Yes
better.
ma'am, please do once. We'll be waiting.
Dr. Bhaskar, yesterday I was in Bangalore
Yeah, how come, sir?
for 2 days, 12th and 13th.
This BMC PG
Yeah,
teaching.
for PG teaching.
But I was not in Bangalore, sir.
Yeah.
I had Calicut DNB accreditation.
It is actually known fact that Bhaskar will not be in Bangalore. He'll be somewhere else.
DNB hospital accreditation was there, sir. So I had to go.
Right.
Good evening, Bhaskar sir. Good evening,
Good
sir.
evening, sir.
Yes, good evening.
Sir, good evening, Baldev sir.
Yes, good evening, Dr. Ashwada.
Sir, you didn't come for Mysuru, sir? Bhaskar sir.
No,
Kaveri Pedikar.
No, I didn't.
I thought you'll be definitely be there.
Somewhere else.
Narayanappa sir was also missed.
Now he is a principal, no? So he has many work now.
Palani Raman sir also is there.
Huh?
Good evening, Yashwant. Good evening, everyone.
Yes, good evening.
Good evening, Bhaskar. Good evening,
Ah,
Bhaskar.
good evening, good evening, good evening.
Silently listening, Palani. Silently will be listening. In OP, yeah?
No. Take, finish the OPD. Just now finish the OPD.
Okay, okay.
So early.
Good evening, Baldev, sir.
Yes, good evening, sir.
Good evening, sir.
I think Srinivasan sir is also finding same difficulty in joining.
I think that's how I'm trying to. Sir, good evening. Oh, she.
I don't know what is the problem. Again, I think she's not able to join or what.
Yeah. And Chetan, others also must be finding the difficulty.
Any
I
Chetan,
don't know. Basically, because I have shared the same link. Wait. If I am able to join with the same link, see, I am now.
Even I could do.
See, I am just. See, I joined with the same link.
I talked to madam, she is joining without camera. मैंने बोला ओके ठीक, कुछ दिक्कत नहीं है, बलदेव भाई सर को थोड़ा सा प्रॉब्लम आ सकता है, लेकिन सी जॉइनिंग विदाउट कैमरा. ठीक है.
Okay.
अनम्यूट चेतन जी, अनम्यूट करो.
Same link I used and I am able to join it.
I think then you can send Dr. Tanu the same link.
7.5.
Resend.
Same. Nini, the link which I sent to her, no, I clicked the same link and I am able to join. She's joining something else.
Because I think others also must be finding the difficulty.
हाँ, क्योंकि एक्चुअली हमारा ये इसके डैश के ऊपर भी बहुत लोग रहते हैं, 7-8 लोग.
हाँ, काफी लोग आते हैं.
पता नहीं, because I have put in that also, EB also.
Even
Yashwant
Dr.
also joined.
Dr. Bala, Dr. Vijay, they are always there.
Dr. Vijay Evle sir should join. I don't know. Let me call him also. Meanwhile, Tanu ma'am.
Good evening, Sanjay. Good evening, Chetan.
Good evening, sir.
Yeah, good evening, Dr.
Good evening.
Palani.
Yes.
Hi. You joined with the same link, right, Dr. Palani also, Dr. Yashwant also.
Yes, same link.
Yeah,
No
yeah,
issues.
same link, same link.
No issues.
Sanjay bhai, namaste.
Sir, are you joining for ID case?
नमस्ते.
Oh, same. Okay, fine, no problem. Just wanted to see. This शुरू करते लेकिन वो लिंक का कुछ प्रॉब्लम इसलिए I was just wanted to ask you have problem joining or something else? No problem. I'll wait. Okay, you come afterwards. No problem. Yevle sir is busy, that's why he's not joined. Otherwise, now problem is of Tanu ma'am only. Bhunat jo hoga. Baji.
Good evening, sir.
Good evening, Dr. Nandini.
Good evening.
Good evening, madam.
Dr.
Good
Jan.
evening.
Good evening, Good evening, Bhaskar Thelai, sir.
Yes, good evening.
Sir,
Good
good
evening.
evening.
Good
Tanu
I
ma'am
think
came.
now
Tanu
Dr.
ma'am, are you
Tanu
there?
Dr. Tanu is seen.
Yes, yes, I'm there.
Yeah. I think
Okay.
without cameras, but she's
Hey,
there.
there is something, somebody told there may be a problem of camera shutter.
No, I don't know. I think my
No,
video
that
is
your
on.
laptop, see, like this. Okay, then it will show like this because laptop, there is a shutter where the camera eye is there.
Backside.
No, front only. Mine is front side. I don't know what ma'am is having.
Okay, now I don't know, but my video is on. You can't see me?
No, no,
Or
no.
you are not seen, you are heard.
Okay,
Anyway,
but
ma'am,
let's
do
see.
one thing. No,
Let's see.
you share and we let us start the things.
Yes, 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 please.
I think before that we'll start the things proceedings. Okay, sorry and good evening everyone for okay, ma'am. You are
Tanu,
seen now.
seen. Yes, yes,
You are
Tanu, you are
seen.
seen.
You are
I don't know, but I want you to see my PPT. Yeah.
Now you are seen, so PPT will be also seen.
Shall I share my slides?
Yes, please. No, okay, just wait a minute. It was for 5 minutes, 2 minutes.
Okay.
Okay. So, good evening and welcome all the viewers for this another link of ID case series. And as you know that Dr. Tanu Singhal ma'am is presenting a case, and with the help of our ID experts of the country, we are trying to decode the case. And as we know that this is absolutely extempore discussion which is going to happen because not a single person other than Tanu ma'am knows the case. And that's why we have a Diggaj of ID. Initially, we had Dr. Bala sir, we have Dr. Vijay Evle, and now teacher, Dr. Baldev Prajapati sir. Welcome, sir. So first, I will request Dr. Bhaskar Sharma, the chairperson of ID chapter, to welcome all.
Thank you, Dr. Chetan. Respected Baldev sir, Dr. Tanu. Thank you, Dr. Tanu, for conducting this program continuously, and it has become the much awaited program for most of our members. And today we have none other than Dr. Baldev Prajapati to decode the case, and it is going to be a jugalbandi for us. And two stalwarts are sitting, and what more we want. So thank you so much for joining. Without wasting much time, I hand over to Chetan for further proceedings.
Yes. Okay. So, ma'am, I think you don't require any introduction, nor the Baldev sir. So let us start
Yes.
the meeting. Stage is all yours.
Yeah, sorry that there is because of some glitch. I don't know why you can't see me. So I will just share my screen.
Yeah,
Yes,
share the
ma'am.
screen.
Yes, that is better, ma'am.
Just 1 minute. Can you see the screen?
No, ma'am.
No, not now. Dr. Alina.
Can you
Yes,
save the screen now?
Alina.
Yes, madam. Yes.
Yes, yes.
Okay, so we'll start, and actually today we have not one, but actually we have two cases because I didn't find one long enough case, so I thought it'll get over very quickly. So that's why we have two cases today for you, Dr. Baldev.
Yes, madam.
Yeah. So actually not two, but there's a three cases. The third case is just, I just present a very short case, and these are related to bone and joints. Okay. And they are mainly messages related to the diagnosis. So shall we start, sir?
Yes, madam. From my side, I'm okay.
Yeah. So we come to the first case. This case is about 2.5 years ago that I saw. This was a 5-year-old boy who presented in February 2023, and the mother said that he had pain and swelling of the right forearm since 15 to 20 days, and he had high fever of 1 day duration. So he initially started with pain and swelling, and maybe she gave some history that he had hit his arm, like many of the times you get this history, and fever for 1 day. And when he came to the OPD, he actually presented to the pediatric orthopedic surgeon, and he examined and he said there was swelling and tenderness of the right proximal forearm, and he immediately did an X-ray, and you can see that this is the humerus, this is the ulna, this is the radius. And he said that there did seem to be some abnormality in the middle part of the radius. The count was done and the count was normal, but the CRP was very high and the ESR was very high. So at that time, I mean, with these findings, sir, what do you think could be happening here? Like, what would come to your mind with this kind of history?
Yeah. Good evening, friends, and Dr. Tanu. Let me express our gratitude to the office bearers for giving me this opportunity to interact with you, and particularly all our friends of ID chapter. I think the story is 5 years old boy, and as you said, 50, the pain and swelling of the right forearms is almost 2 to 3 weeks, but fever for a day only. So I think first there is the pain and swelling and then the fever. If we try to understand that means something disease process was there, and now the probably fever has started. And then already pediatric orthopedic surgeon has commented that there is swelling and tenderness, and even with this X-ray. So very first thing will come to my mind that before this problem, child might have some, I would say, trauma or injury, and then there may be some fracture or so, and then probably fever might have drawn. The fracture probably may not be very significant, otherwise probably 2 to 3 weeks they may not wait. That is the first thing, but at the same time, yes, acute phase reactants are increased, but to my surprise, the count is within normal limits. I'm not sure whether it is maybe really technical issue of the laboratory or in true sense it is less. Both the ways I will have to consider. So the first impression, what I will consider as some trauma or something, and then the osteomyelitis. Or that I think that is the first impression. Then let me go in the details with more informations.
So, what would you like to do next? So, your impression is that maybe the child suffered a trauma and then maybe he developed.
I think first history in the details, Dr. Tanu, that really is it the story like this, that the first pain and swelling, and then before that, was there any history? Because 5 years old boy, so probably must be under the care of somebody. It will not be, I will say, alone going to play or even might not be going to the school.
So there was no significant history of trauma.
Okay. So trauma was not significant. Then I think immediate but still infection is the first possibility. Even non-infective condition also then I will have to keep in mind. And that may be in the form of even the scurvy, but I think that is not the site, or even some other condition like really hyperostosis due to some reason. But then again, the leukocytosis is expected. But I think first, with this, really, if this is information, further information is not available, then I should go for the MRI of that part.
Right, exactly. So that was done. So MRI was done, and this MRI showed that here you can see that, in the radius, it showed extensive marrow edema with periosteal reaction in the proximal radius and diaphysis, with central necrotic focus with edema in the surrounding muscle. So, I mean, the radiologist who interpreted the MRI said that this looks like osteomyelitis to him. So how would you proceed
Yeah.
in this patient?
I think from this MRI, as already you said, and this opined by the radiologist, that yes, it is the inflammation of the bone and probably infective, and in that case, osteomyelitis. But I think acute osteomyelitis or bacterial, one of the possibilities, even in spite of the normal count. But tuberculosis, then probably maybe in the good consideration as a etiology. Yes, it is infection, bone infection. First, I will say bacterial infection. Second, even the tuberculosis. That will be my, I would say, way of thinking.
So, I mean, this is diaphyseal involvement. So, isn't that
Yeah.
kind of odd for bacterial osteomyelitis?
Absolutely, absolutely. Because all of us know that the metaphysis is a very common site where it should be there. But even the, I think may not be common, but still I'm not sure whether is it so that the diaphysis should never have this problem of the infection, or second, even non-infective, some conditions now I will consider. That is really hyperostosis, which already I commented even, that is the
somebody has
Kaufes.
mentioned in the chat box.
Kaufes disease.
Yeah.
But I think again, Kaufes disease, the point is, it should be severe pain, tenderness, child will be irritable, even young age children are common, but 5 years okay. And second thing, leukocytosis is common, but still probably that. Second, even maybe some secondaries also, that, or even the third possibility, further possibility, malignancy also I will have to keep in mind. So my order of thinking would be like this, that infection, if I consider probably tuberculosis, bacterial goes down, then even the Kaufes disease, that malignancy itself at the site, or even the secondary at that particular point.
Would you want to do a bone biopsy, or would you
Yes.
start empirical therapy?
No, I think there is no question of therapy. First, naturally, I would like to confirm, and we can do, I would like to request this pediatric orthopedic surgeon that under this radio imaging, with the help of even the radiologist, we should go for this, even the biopsy. And I'm sure that that will be more informative, probably may guide me or may give the diagnosis.
Okay. So anyways, so here, what we actually did is that
Right.
We did not go ahead and do a biopsy, thought maybe that this is acute osteomyelitis, so started treatment with IV cloxacillin, and there was rapid subsidence of fever, decrease in swelling and pain. CRP declined in 2 days to 40 milligrams per liter, and the patient was discharged to complete 2 weeks of IV antibiotics and then given oral cephalexin, etc. I mean, this is what we did. Of course, the story is not over here. Otherwise, I wouldn't be presenting.
But Dr. Tanu, may I make one comment? I agree with you that somebody goes in this way, that let me start the treatment and see the response.
Yeah.
And if not happy, then I will go for this. Yeah.
That we thought that,
but I think with the development, what you said, that you are happy with the antibiotics, there was some response. I'm not sure whether we should wait till the patient comes back.
That because we are presenting this case here, we know that this is not a straightforward case of osteomyelitis.
So patient should come back. Patient should come back.
Will come back, yes. So I think you've already answered the question that you had said that in the first go only you would have done a biopsy, and you would not have started empiric therapy here.
But madam, suppose if I request the pediatric orthopedic surgeon, and if he also agrees, I think first I will go for the biopsy, and then probably may start or even along with the antibiotics, I will go for the biopsy.
Okay. Let me just read the chat and see that if people have said something else.
Right.
Yeah. So some person has said, since unusual site, do a close follow-up. Anyway, so this patient was asymptomatic for the next 6 months. So, and then when we did a X-ray done 3 months later, it showed significant cortical thickening. You can see that the radius, you can see that the bone is thickened. Sometimes you see this in a patient of osteomyelitis, the bone is very thick as a reactionary process. But in September 2023, the patient comes back with significant swelling of the forearm again. And now, what are your thoughts?
I
So
think
since he remains okay.
I think strongly now, I think it should be the Caffey's disease, hyperosteosis. And that may happen even without the antibiotic also. Sometimes the patient may improve. Even
Because
though
I
that
must
was a
tell you
fever.
that when he had got admitted
Right.
with the fever
And-
and that pain, we had given him ibuprofen also for 2
Right.
days.
And,
So
and
we don't know
second,
whether the response-
second always the malignancy should be kept in mind. And therefore even I will insist that better to go for the biopsy, even along with the antibiotics.
Okay. So we did repeat MRIs, and if you can see, the repeat MRIs
Yeah.
are showing that there is intense inflammation, showing extensive marrow abnormality, periosteal reaction, and you can see the muscles. The muscles are swollen
inflamed.
completely. So after looking at these MRI images, what is your thought? Does it look like a malignancy or does it still look like an infection? Do you think this patient has got a relapse of his infection? You can see here. You can see there is a necrotic focus in the bone over here.
Sorry, I'm not good in interpreting this MRI, but as you interpreted, I may consider. But now what I believe or I think that infection probably little bit goes down and probably maybe the malignancy. I think here again, I will go to the pediatric orthopedic surgeon. We'll discuss with him. Even we'll take his opinion and his thoughts and insist that better to go for this even biopsy at present.
So you said that yes. So they thought that there is chronic osteomyelitis with pyomyositis was considered. The patient was taken up for exploration, and plenty of pus was present. The pediatric orthopedic surgeon said that so much pus was present. He debrided the entire pus, and samples were sent for histopathology, aerobic cultures, gene expert, midget culture. But 48 hours later, all the cultures come negative. The gene expert also comes negative. So, how do you explain this? I mean, so much pus present, and yet the cultures are all negative.
So I think here I will think in this way that yes, because pus is there, I will have to believe that the infection was there. But is it the primary or primary disease is something else? And this infection has taken as a secondary. In that way, I will have to think. Suppose really it is primary, then probably some unusual organism which may not be which we are accustomed to see with the acute osteomyelitis, like that organisms may not be there, some unusual that may be even due to the basic problems of the host. Maybe there's some immunocompromised status or primary immunodeficiency disorder or something. That is one aspect, if it is really primary infection is there. Or second thought, as I said, that the basic disease is something else, and this passes due to the secondary infection. In that way, I will consider.
You are spot on, Dr. Baldev, because this patient actually, and somebody has mentioned the diagnosis in the chat box. This is actually Ewing's. It turned out to be Ewing's sarcoma. Dr. Palani Raman has mentioned the diagnosis in the chat box, and you were right in the beginning because you did say that the first diagnosis you said was an infection, second diagnosis you said was cafes, and third you thought of a malignancy. Though you didn't talk about the type of malignancy, but Ewing's is a very, very close differential of osteomyelitis. And you did, when we looked at the histopathology, these round blue cells are actually the cells of Ewing's sarcoma, which were actually there and which were infiltrating the bone and were also infiltrating the skeletal muscle. So, I mean, and we all know that Ewing sarcoma and acute osteomyelitis are both resemble each other clinically and radiologically. In fact, they both can look exactly the same on the MRI. But now the main reason, I mean, what makes this case very unusual, and the reason for presenting this case is that why did the patient respond to antibiotics the first time? And why did the patient remain asymptomatic for 6 months? And that is the question which I really want to pose to you. That Ewing sarcoma is supposed to be a very, very aggressive bone tumor. And how did the patient become better the first time, and why did he remain well for 6 months?
Yeah, I think first let me mention that Ewing sarcoma, probably I might have seen 3-4 patients. That means less numbers of the patients, not I will say multiple patients. But yes, heard and even read a lot. And in pediatric, particularly the malignancy, that to particular mass related to the bones, Ewing sarcoma is the most common. And second point, yes, that's why I think from the beginning I was mentioning, yes, you said I didn't mention Ewing sarcoma, but the malignancy. And I meant that this Ewing sarcoma, because very difficult to differentiate clinically. Even some people say radiologically from the osteomyelitis. But yes, as some of the points you mentioned and quite convincing that for osteomyelitis, that was not the site. Probably maybe the common site for the Ewing sarcoma. That may be the, but I think both the differential diagnosis and my strong point will be in this situation, I will go for the biopsy. Even I may start the antibiotics, but I will not leave only to the antibiotics. I will go for the biopsy. That's a very, I would say, strong point from me. Second, I think initially malignancy may be the beginning. And meanwhile, you know that by the hematogenous route spread, there may be the bacteria loss at the, and that is very common, even pathophysiology, we know that once there is something, some part of the, any part of the body is affected in the phase of the bacteremia, that becomes the site of the infection. That is very well known, I will say, for any type of the infection. And therefore, probably osteomyelitis like picture developed, we got the pus treated, and somehow the patient showed the improvement. Even sarcoma, even I know that it's not the like acute lymphoblastic leukemia. It takes even months to gather and probably might have remained asymptomatic for 6 months. This is the thing which I can offer the explanation. Thank you. Dr. Tanu.
Yeah, so we also did a kind of literature review to see whether there were these kind of cases. So there was this, case report from about a 24-year-old patient, exactly like our case, who had a history of pain in the right arm and fever. And in fact, in which a biopsy was also done, and which showed osteomyelitis. And each episode responded to antibiotic treatment. And a second biopsy was performed 3 years later, and it confirmed the diagnosis of Ewing sarcoma. And here, there was a 3-year delay in diagnosis.
Yeah, 3 years, yes.
So, the case report highlights an atypical facet of the natural history of Ewing sarcoma, a response to antibiotic and anti-inflammatory agents, and the limited stage of the disease despite a misdiagnosis of 3 years. And this suggests the possibility that anti-inflammatory agents exert an inhibitory effect on the tumor growth.
Okay.
So, and as I told you that the first time when the child was admitted with us, for the first couple of days, we gave him ibuprofen along with the cloxacillin. So it is possible that the ibuprofen actually brought his CRP down from 255 to 40, which we attributed to cloxacillin. So it is possible that the response was due to ibuprofen and not due to cloxacillin. And in our patient, the gap between the first and second episode was 6 months. But here we have a case where it was 3 years. And then we also found another case report. This was from the UK, in which there was an adult female who had cervical lymphadenitis, which was diagnosed as TB. And then she had presented with a tibial swelling. And there they thought that this was probably because she had lymph node TB in the neck and she had a tibial swelling. And therefore they thought that this must be TB osteomyelitis. So they actually did a biopsy of that tibial swelling. And it was reported as granulation tissue consistent with TB. And she was treated as TB. Then in 1999, when that swelling reappeared, in the same site, they did a biopsy and it was then found to be Ewing's. So the point which I wanted to make here is that these were two cases where not only there was a clinical and radiological presentation as osteomyelitis, but even the histology was confused to be as osteomyelitis.
Yeah.
So I think the main message, and these were two cases in which there was a delay of 3 and 4 years as, in making a diagnosis of Ewing sarcoma. So I think with that,
I think just one point, Dr. Tanu, I was aware that even clinically and probably radio imaging point of view, we may not be able to differentiate. But here you added that even the histopathology was not able to help. And they took very long time, some years, and Dr. Tanu took only 6 months. So I think it's...
the problem was in both these cases, it was a needle biopsy. Maybe if you do a needle biopsy, you may not get enough tissue. You may not achieve, because needle biopsies are very small fragments you get. So if you get a necrotic material, you may not be able to diagnose Ewing's.
Then misguide you, yes.
And may misguide you.
Yeah.
So that is also an important point I wanted to make. But congratulations, Dr. Prajapati, that you made a diagnosis that it could be a malignancy right from the first discussion. And I think Dr. Palani Raman, who also
even he targeted the condition
in the first thing. And I think the main message which you want to give to the audience is that if you have an unusual presentation of osteomyelitis, especially when it is involving the diaphysis, then we must go for a biopsy diagnosis rather than starting empirical therapy. Okay, now we move on to the second case. Now, this is the case of, again, a 5-year-old girl who presented to us last year, who had pain in her left lower jaw with swelling of the left upper anterior cervical node. Okay, so that means she comes with swelling, and the tooth appeared to be normal, because when you have a swelling of the upper jaw node, you start wondering whether it is some kind of tooth problem, because you know that the teeth drain into the node. She was given oral coamoxiclav, but the pain and swelling of the node did not subside. Please mute, whoever is unmuted, please mute. And then a count was done, which was 19,000. CRP was high, ESR was high. And then this lymph node, which was red and inflamed, it formed an abscess. So the patient underwent an incision and drainage of the abscess, and the cultures were sent. Aerobic cultures were negative. Gene expert was negative, but no histopathology was done. And this patient was discharged on coamoxiclav and linezolid. I don't have any pictures of the lymph node swelling at that time, so I can't share it with you. Now, Dr. Prajapati, if you have a patient coming to you like this, who comes to you with a bacterial not bacterial, but let's say an acute lymphadenitis like this, would you agree with whatever has been done, or would you do something else also over here?
Dr. Tanu, was there fever? Because that you have not mentioned.
No, there was no fever.
There was no fever at all?
No.
Yeah, because
she just had pain in the jaw, and she had swelling of that lymph node.
Because it makes difference in the thought process, because even as you said, not even the mild fever. So because you have not mentioned the fever at all.
I don't recall that she had fever. She developed fever later. Later she developed fever, but initially there was no fever.
Okay. Anyway, but presented with the left lower jaw, which, as you said, cervical lymphadenopathy. And then, so I think here the fever is not there initially. I think later on, whatever you give the information will change our thought. But then the infection comes down. Even the non-infective inflammatory conditions like even Kawasaki, which with the anterior cervical node we will consider, in the absence of fever, probably, if at all I consider, they will go down. Then what other conditions? I think
lymphadenitis, acute to subacute lymphadenitis.
Yeah, and that too, even the
suppurating
anterior cervical. So I think that number one, even the non-mycobacterial tuberculosis that we can consider, and it is known, it can present in this way, or even the abscess you said, and even gene expert. But I think here naturally AFB should be seen. I am sure whether the ZN stain was done.
ZN stain, I think, was done, which was negative.
Yeah, because suppose ZN stain is positive and the gene expert negative, then it clinches the diagnosis. But if you say that ZN stain was negative, gene expert both were negative, then probably it goes down in the thought process. And then again, this type of some organisms will have to consider that, and there is only one cervical node, no other lymphadenopathy, or
Yeah,
even
it
the
was only
axillary
one node.
inguinal.
It was only one node.
Only
The
one.
patient just had one node.
If it was only one, that means it is the local, whatever the pathology should be the local one. It might be I will say draining from some area, and jaw swelling if you are mentioning.
The swelling was not of the jaw. The
Yeah.
swelling was only
of the lymphadenopathy. Okay. So I think then infection from the local area we'll have to consider. Whatever it is, we'll have to go in the details. But the point is, I think here rather than I will go for the total lymph node excision biopsy and even the proper all the investigations, including best histopathology.
Yeah, so your thing, you would have done, you would have liked to do a histopathology also.
Yeah, histopathology.
Because you would have seen if there are any granulomas there. That
I think lot many informations from the histopathology.
And
so
do you agree with this thing of giving linezolid here? Like
no. I think linezolid, I don't know why. Already co-amoxiclav, you started, you can make it even the oral route. That's
what
all.
is the hazard of giving linezolid here?
I think linezolid, all of us know several times we have mentioned that unless really the strong indication, please don't go. Even the linezolid are very important, and that too, and I will say to treat the subacute lymphadenitis, there is no indication. And even the indication, suppose some other option, better to choose it. Linezolid, we know that for the MDR, TB, and for so many other conditions, it is useful. Even difficult staph problems. So in that case, we should use it in the defined indications, not, I will say, in this situation.
Okay. So yeah, because it would confuse if it was TB or NTM.
Yeah.
For both, linezolid works. Anyway.
Therefore, I will say lymph node excision biopsy material should be examined for gram stain, germ stain, culture, even these gene expert, and even the histopathology examination. This is very important. And antibiotic, if somebody wants to go co-amoxiclav, if you have started IV, switch on to the oral route. Probably nothing specific further change of antibiotics is indicated in this situation.
So, the post the surgery, the pain persisted and the child developed a swelling of the jaw area. And the child had taken dental opinions and OPG had been done. This is the picture of the OPG. Because obviously now if the patient had an abscess here and the swelling of the jaw had developed later, therefore everybody starts wondering whether it's a tooth problem, because the tooth is draining down there. And therefore the parents presented to me for second opinion, and specific reason for them to come to me was whether this can be TB. That was the reason, because everybody knows me as a kind of TB specialist. So they came to me asking me whether this can be TB. And actually, I really didn't think that this could be TB. And especially now when there was pain and swelling of the jaw area. So I actually, and Dr. Prajapati, do you think this could be tuberculosis?
I'm not sure regarding this case, but Dr. Tanu, I have seen two patients with tuberculosis of the jaw area and one even sternal tuberculosis. Sternal just last 1 year. So unusual sites point of view. So I think I may consider one of the possibilities. Yes, I think I may not exclude it totally, even with the gene expert negative. Again,
yes,
probably
gene expert is positive only 50% of the time.
Yeah, that's why I will say negative does not exclude it. I will keep in mind, and therefore I was insisting for the histopathology. So again, I think with this, we should take the help of appropriate person to, I will say, particularly the orthopedic surgeon or good dental surgeon who is confident to take the material out and to go for the proper examination from all the points of view.
Okay. Okay. So that's what. So I actually sent the patient back to the dental surgeon, and the dental surgeon, he went in and did a thorough examination because I somehow felt that the dental was the cause. So he went in and he wrote his notes. He said basically 74 is the, the left lower first molar, and 73 is the left lower canine. The poor child had to sacrifice her,
Teeth.
these teeth. And when he basically couldn't identify much in the teeth, but they said that when they removed the teeth, they found some pus exudate seen. So they extracted the teeth, they found some pus, and they sent all that, whatever was excised, the tooth and granulation tissue, it was excised and it was given for biopsy. And the patient was discharged on oral coamoxiclav and metronidazole, which is what they give for a tooth infection.
Yeah.
And the gram stain showed gram-negative cocobacilli, which are probably anaerobic bacilli coming from the mouth. The aerobic culture showed Streptococcus sanguinis, which is again aerobic, which are, oral flora, Enterobacter cloacae, which is again probably some kind of colonizing bacteria there. And the histopathology of whatever was sent showed non-specific inflammation and necrosis. There was no kind of granulomas or anything to suggest TB there. So there was some inflammation there, but there was nothing to suggest TB. Now, after all this was done, I mean, how do you interpret these reports? Do you think the child had some dental infection which gave rise to the lymphadenitis here?
I think infection, okay, but these organisms, what they mentioned, the Streptococcus sanguinis and Enterobacter cloacae, I think we know at least these are not the common organisms for us. So really we should consider or talk to even the microbiologists that how much we should give the weightage or importance to these organisms responsible for the disease process. And really, if it is so, sometimes because I think nowadays we are learning from the microbiologists that really some unusual organism is responsible for the disease process. There is some specific reason with the host that probably we should try to define. So I think once somebody has given that these organisms were seen, better to, I would like to learn from microbiologists
I'm
that
telling you,
what importance should be given to these organisms. Or I think Tanu is the right person. Please.
so I'm telling you, I would not give any importance to these
Okay,
organisms at all.
okay.
Because
So
Streptococcus sanguinis is normally present.
otherwise it can be there.
And
Right.
Enterobacter cloacae is a very common colonizing bacteria. It will come in any patient who's been on
Right.
antibiotics. It's like Pseudomonas aeruginosa, you can
Right,
find
right.
it anywhere.
Anyway, so you made my point clear that don't give them
Yes.
undue
Yeah.
importance. Right.
Yes, so wouldn't give any importance to these bacteria at all.
Then I think suppose lymph node is removed, teeth removed, and patient is happy, then I may not go for further any problem unless there is some further information.
So you think now things have been sorted out? They said that when they remove the,
I understand.
no
I
dental
understand. I
decay.
understand. It may not be so simple.
Yeah, because clinically an intraoral swelling was seen, then
Right.
no dental decay or fracture could be detected. Because sometimes what happens is that overtly the tooth seems fine, but there is a periapical abscess inside. But when they actually, however, they did an access opening and pus exudate was seen. So we don't know whether the tooth was healthy and deep down there was an abscess which was actually
Right.
causing a reactive lymphadenitis. So at that time, maybe they thought there's removal of the teeth, clearing out that pus and everything sorted it. But the story does not end here.
Yeah.
The pain and headache and swelling persists. The
headache,
child
yeah.
is continuing to have pain and headache and swelling. Now, more than 1 month into the illness, has been on antibiotics for 1 month, and then she undergoes CT and MRI of jaw and brain because the headache is so severe. And probably I think it's a referred headache because of the pain. Whenever you have pain in the face, you have pain in the head. So MRI brain is normal. But when you do an MRI of the jaw, you find that she has developed mandibular osteomyelitis. So she has developed mandibular osteomyelitis of the left side of the mandibular body. with associated small collection. She has developed an inflammatory change of the left buccal mucosa and buccal fat, and she has reactive enlarged bilateral cervical lymph nodes are seen.
So I think, yes.
So now she's continuing to be symptomatic, like even after removal of the tooth and the lymph node,
Right.
and giving her antibiotics because she's on, I think, coamoxiclav and metronidazole. She's been on antibiotics for 1 month, and yet her symptoms are not getting better, and she started getting fever also.
Yeah, I was asking the same thing. Is there fever?
Yes, she
Okay.
started getting fever also now.
So now I think these type of situation we'll have to keep again 2-3 possibilities. I think in this situation, I will consider number one possibility, which is very common, is the tuberculosis. We'll have to rule it out. And
But
for
you know,
that,
we had done that biopsy, Dr. Prajapati.
but I think, madam, histopatho was not done.
That histopath was done. That histopath of the tooth showed that there was just some non-specific.
Okay, tooth was done. Okay. Anyway, but I
it
think
was histopath of the tooth.
Yeah.
They had not kind of gone into the mandible.
I think so. Again, as I will say, I will discuss with the friends that what specimen I can get it, but I would like to go for further confirmation for tuberculosis, number one. Second, suppose tuberculosis is not there, then again, this jaw is the site where even the other uncommon organisms are known, insects and other, or even the again, histiocytosis or some malignancy. I'm not sure how much, to be very frank, clinical experience point of view, somebody asked, I have not come across, but it remains one of the possibilities, and that we should consider. And for, I think, confirmation provided, even sometimes even fungal infections, because they are known even to reach these areas. And for that, ultimately, I will say I would like to go for the guidance of the radio imaging and take the proper specimen for further examination. That is the histopatho, all stains and all cultures.
So fine. So that
even
was
even I think now lymph nodes are also seen. So if it is accessible,
they're
very easy to approach, then small lymph nodes. Okay.
So that's what happens. The patient undergoes the third surgery. She underwent debridement and curettage of the left mandible. The pus is sent for histopath and cultures. Empirically, she's given ceftriaxone, teicoplanin, and metronidazole. The cultures are negative. The PCR is negative because now they do the molecular PCR also. The histopath, acute inflammation, they send it for gene expert. They also send it for fungal cultures. That is also negative. The pain and headache continues. And all this is now happening. The patient had not come back to me. She had come back to me after the dental surgery, and when she had come and I had sent her to the dentist, and all this has happened. Now she has undergone 3 surgeries. The first was the lymph node. The second was the dental surgery when she lost her tooth. And now she's also undergone surgery of the mandible. And as you said, the mandible biopsy has happened. It just shows acute inflammation.
Right.
And
but I think, as you have mentioned, pain and headache continues. So I think I would like to focus over that. That headache, whether can you give any details is available? Because headache can be due to this reason itself, only nothing else.
Yeah, or because an MRI brain was also done, and the MRI brain also showed that there was nothing in the brain.
Okay, that's why I was asking
whether headache. It's referred headache because whenever you have a boil in your nose, also you get headache.
Right. So I think that was due to referred pain. Otherwise, I was thinking there is an extension of the disease process to other skull bones or even intracranially and a pathology. But you made it clear that MRI brain didn't show any of the things, that local problem. Then I think again locally, I'm not able to name, but then some chronic infections, that is in the fungal, tuberculosis, even non-tuberculous mycobacterium, or even the malignancy remain the strong possibility. And malignancy again can be of any variety, can be of the histiocytosis. I'm not able to name, but some local malignancies are also known.
And this patient has not undergone an image-guided biopsy. This
Right.
patient has undergone a proper curettage of the
Yeah,
mandible.
curettage by removing the debridement and everything. Yeah.
Okay. So I
I
think time
think
to let
beyond that, I'm not able to think. Then you will have to help.
Okay. So I think here, so we did consider the possibility of chronic non-bacterial osteomyelitis or CNO. So I did, I thought that this could be CNO because mandible is one of the places which is the most common site for CNO. So I started naproxen and I referred that patient to Dr. Archana from SRCC. We did a whole body MRI and we found that this patient has lesions in both the humerus and also the femur and acetylpulum. So this was actually a case of chronic non-bacterial or chronic recurrent multifocal osteomyelitis. And someone in the chat had mentioned this as a possibility in the first case.
Yeah.
But I don't know if somebody had mentioned it as the possibility in the second case. Dr. Rashna had mentioned this now. I think, I don't know whether she mentioned it, but yes. So this was a case of CRM. So non-bacterial osteomyelitis. So I think this is CNO or CRMO.
Yeah, I was going to ask the same thing, that is there any basic background to develop this thing?
So this is actually
or any person can develop?
Yes, any person can develop.
Right.
Its usual age of presentation is 7 to 9. It's more common in females as compared to males. Incidence is 4 per million. And the pathophysiology is now believed to be an autoinflammatory disease. Usual presentation is pain or swelling of affected bones. And systemic features of fever, night sweats, and weight loss may be present. And the most common involved bones are mandible, clavicle, pelvis, long bones, vertebral column, or hands. And the labs may show leukocytosis, elevated CRP or ESR, and the best imaging modality is whole body MRI.
Right.
So if you suspect the CRMO and if you do a whole body MRI and you see that you have 2 or 3 sites of involvement, then that confirms the diagnosis. And the other differentials are of infections and tumors. And the treatment is NSAIDs, steroids, bisphosphonates, methotrexate, and anti-TNF. So there is usually a marked delay in diagnosis of CNO because the first time nobody thinks of CNO. You first think of infection or that. Like in this patient, when she presented with that swelling in the jaw, everybody thought of infection, and the possibility of CNO even came to me after a month and a half, especially when she was not responding to antibiotics. And with that, can I just present the last case in 3 or 4 minutes, Dr. Prajapati?
Yes, I think.
Yes, ma'am, you can continue. We have
Because
time
this
because
case-
we started late, so you can take
So
15
this
minutes.
case is just to tell you that this is also an epilogue, like to the previous case, because this is also another presentation of CNO, because this is a 19-month, and this case is so important because this came on the heels of the previous case. So this is a 19-month-old baby who presented with swelling of the left elbow 3 months ago, and the MRI showed osteomyelitis of the distal humerus with joint effusion. And the baby was given oral antibiotics for 2 weeks and there was no improvement. And the repeat MRI showed extension of the osteomyelitis to the left radius and ulna. And this baby underwent surgical debridement. Cultures were negative, no histopathology was done. And the IV antibiotics were given for 8 weeks with meropenem. And then the baby had persistent fever despite antibiotics, and after stopping antibiotics and referred for opinion. So that means this baby had osteomyelitis of the humerus, radius, and ulna.
Yeah,
which was
multiple
culture negative,
places.
and fever continued. And when this patient came to me, the baby had failure. I mean, he was 8.4 kg. His counts were high. Hemoglobin was low. And again, now this child comes 1 month after I diagnosed CRMO in that previous case. तो जैसे सावन के अंधे को सब हरा दिखता है वाला जो चीज, तो मेरे को लगा कि इस बेबी को भी CRMO ही होगा.
Right.
So, because he had osteomyelitis, which was culture negative. So I again considered the possibility of CRMO and I told the patient कि तुम तो फिर से whole body MRI करा लो. So this patient went and spent his, though the patient was non-affording, but he went and did a whole body MRI. And the whole body MRI came back normal. So I was very disappointed. I said that my diagnosis has gone wrong. So I suddenly thought that I don't know what I'm dealing with. But then when I have a case of PO and I don't know what is happening with the patient, I do one thing. I put the patient on naproxen. Okay.
What is the age? Sorry, can you go to the previous slide, madam?
19 months.
Okay, 19-month old.
The
And
patient had
of 3 months ago.
osteomyelitis.
Was there
and-
fever? Was there fever?
Yes. This patient had fever.
Okay,
Fever.
lymphadenopathy?
No lymphadenopathy or organomegaly.
Okay, was there tenderness while handling to the baby?
No. But I then started
Be-
thinking of Sogia. Okay.
Yeah,
Because
yeah.
that glucocytosis and ESR, CRP.
I
So
think
I started thinking
here, okay, but can you go to this X-ray?
Yeah.
I'm not
Poor
sure, but
quality
what
X-ray.
I'm able to see, I think at the end of the bones, I would discuss with the radiologist whether is there a possibility of osteitis or periostitis. I think in that case, syphilis, I may at least give the thought for the syphilis.
Okay.
In this term, but the platelets are normal. Some points are not favoring. Even lymphadenopathy is not there. We can check even the perineal excoriation. But I think in this given situation, infection point of view, syphilis remains for, and it can be even the multiple bones involvement. In the bacterial osteomyelitis.
But that won't explain the fever. The syphilis, suppose this baby had congenital syphilis, he's not going to present with fever right now.
How much fever? I think he didn't mention,
it was
but
quite high, huh? 100,
okay, high grade fever is
actually.
not common. High grade, but otherwise mild fever is going to be there. But you said even organomegaly is not there. Just I will say, in given scenario, one can give the, I will say, thought for the syphilis. That's all. May not be favoring in this patient. Okay.
And though this was the X-ray, but when we did the whole body MRI, the bones were completely normal. Okay. Even the previous osteomyelitis had gone away completely. And the whole body MRI will also tell you a lot about lymph nodes, spleen, liver, most of the things, nothing came up on the whole body MRI. So basically this was PUO.
Yeah, then really we can consider in this way that multiple sites bone, at least osteomyelitis develop with the treatment it got resolved, but then really the basic problem with the host and really the host problem, any immunodeficiency problem, or even that may be the primary or secondary, both the ways we can consider. And again, I think immediately these points come to my mind.
Yes, so you are right. You will consider that there might be some problem with this host because this baby, and I told you that this patient had a history of fevers even before this.
Yeah.
Like even before the onset of osteomyelitis. So fevers, then she got osteomyelitis, and now again she's getting fever. So maybe we are dealing with some kind of immunodeficiency disorder. So I also thought that maybe she has some kind of autoinflammatory disorder or Sogia. So I started naproxen. And after stopping naproxen, the fever came back. So I referred the patient again to Dr. Archana because the CRMO was not there because I didn't find any other osteomyelitis sites.
That you excluded, yes.
Yes. So we did do a whole exome sequencing in this patient. She did do a whole exome sequencing and it turned out to have what is called as Majid syndrome.
Yeah, known.
Yes, in which basically you have a history of recurrent fever, anemia, neutropenia, and it is a variant of CNO.
Yes.
Okay, so in which you can get non-bacterial osteomyelitis. And this patient is unfortunately not doing as well as the other CRMO patient. And it's a rare disease, which is an autosomal recessive autoinflammatory disease, where you have a triad of anemia, a non-bacterial osteomyelitis, and sweet syndrome. And they need other modalities. So this is a variant of CNO.
Yes, variant of it.
Yeah.
But I think what usually all of us know that we consider in this kind of situation, we'll first check the disease process. Secondly, I will say host. And third, keep in mind the environment. And probably if we check one by one, we may get some answer.
Yes. So I think, thank you, Dr. Prajapati. That was wonderful discussion with you. So I think in this discussion today, I discussed non-infectious mimics of infection. And as you will agree, these non-infectious mimics, whether it was Ewing sarcoma or whether it is chronic non-bacterial osteomyelitis, share clinical, laboratory, and radiological features. And basically, persistent second opinions, invasive tests, and
Yeah.
advanced diagnostics help in making the diagnosis, because biopsies and exome sequencing and second opinions, etc., helped in making the diagnosis in these patients. So I think with that, I would like to end my presentation and turn it over to the moderators, Dr. Baldev, for your things, and other people on the, the experts for their, for their inputs on the cases.
Thank you so much, ma'am.
I think Dr. Chetan, before you go
Yeah,
for
yeah.
this
Yeah,
remark,
sir, I would like to have your comments first.
let me express a word of gratitude to Dr. Tanu for certainly, I will say, bringing up the good cases, even some of the conditions, eye-opener for us, that we'll have to go even beyond this, our common thoughts, and certainly learned a lot. And once again, a word of gratitude to even the Chetan, Dr. Bhaskar, and all the office bearers for giving me this opportunity. Thank you very much.
Thank you so much, sir. I think there are so many comments on YouTube because that was going on live. There were many comments on the way when that case was discussed by Dr. Mahesh Mohite, Dr. Subramaniam, Dr. Anantha, Dr. Tilak, Dr. Shyam Sarodaya, Dr. Mandirata, Umar Qureshi. So many people have given, inputs during the case. And it was really wonderful, and cases. Definitely, it was making ID case series case, not a routine cases. And for that, I think Dr. Baldev Prajapati was the ideal choice for all of us. So, anyone would like to express something? Maybe Dr. Palani Raman?
Thank you. It's a wonderful time we had in the evening. It's a nice, actually, the brainstorming session. Thank you. Thank you, madam, both for madam and Baldev sir. Thank you, sir.
Dr. Yevle sir joined late, but I think if he could catch hold of one or two cases.
No. Unfortunately, I joined in the last 2 minutes. I'll go through the recording, but I believe it must have been a great discussion. I missed it today, but I'll join. I'll look at the recording.
Yeah, it was bone and joint infection majorly this time. Yeah. Dr. Pramod Kulkarni, thanks for being so active all throughout. Dr. Pramod Kulkarni, can share your views or comments?
Thank you, Chetan. The only atypical thing, I have seen few cases of CNO, but I have never seen local adenopathy with abscess formation. That's quite atypical. That was a little atypical thing for me to think of.
Yes, that was something which was odd in this patient, and that is what made not think of it
for
right
other
away.
conditions.
Yes. That was odd here, definitely.
So I saw one last slide, where you showed the counts and you entered in a diagnosis of Sogia, but the slide at least displayed lymphocytic count.
Yeah.
So, do you get Sogia with lymphocytic count?
Yeah, so that was not fitting in. And also, of course, in maybe a 19-month-old baby, you may not see that much neutrophilia, but it was a desperate thing because I was not able to make any diagnosis. So it was just a stopgap thing, I think.
My question is, non-neutrophilia or lymphocytic predominance, does it rule out?
No, it is not. It is not in favor. And that diagnosis was also not right because
No,
later on
per
it
se,
turned out that it is not.
osteomyelitis doesn't fit into Sogia at all. It is arthritis only, never osteomyelitis.
No. I never said. I said that osteomyelitis was not a part, but I said the fever which came after the osteomyelitis, I was not able to make a diagnosis of what was causing that fever. And we did a whole body MRI that was negative. So sometimes in a case of PUO, when you are not able to make a diagnosis, you just put the patient on naproxen as a stopgap thing till you can make an alternative diagnosis. So that's what I did. But I agree, the diagnosis of Sogia was not correct.
I think, Dr. Tanu, the reason is, already you are knowing that there is something is wrong with the long bones, some infective process. Then I think even the second thought will not give to the Sogia.
Yeah,
Because,
so as I said,
yeah.
that it was, I said Sogia query some inflammatory state. I have mentioned that it is
Yes.
inflammatory state. So that is why I put the patient on naproxen till you really know what is happening. Because sometimes it happens that, you have done everything and you can't reach a diagnosis.
You don't
and
have the
get
answer,
stresses.
then
You don't have the answer.
then you consider.
Are desperately you do that.
Yeah.
And
we may not be able to explain the points, but
yeah,
we consider
and
it.
then and I've said that it is not Sogia, but I've said Sogia / inflammatory state.
Yes.
Because later on it did
Some
turn out to be
unexplainable
an
inflammatory condition.
inflammatory condition.
Yeah.
And then later on, it turned out to be an autoinflammatory state only. Yeah.
But Dr. Tanu, I will take the little bit liberty for this type of point, at least for the other friends. And usually in my round, what I have the habit that I will put the note that having this type of the picture, probably I don't have the exact proper explanation, but considering some inflammatory chronic condition, likely this type of some autoinflammatory condition, and considering this thing, I start this naproxen or NCID like that. So, it becomes clear that we have understood that we don't have the answer, but we consider some unexplainable or unclear, I will say, autoinflammatory condition, and we just want to give the trial of the drug.
Yeah, because what you have to do is that while you are looking for the answer, you have to at least start some treatment which is not harmful to the patient.
Yes. But at the same time, if you put this explanation, even I tell my student that suppose if the patient goes to some other consultant, that consultant will understand that exactly what was your problem and that why you have considered. That you will, I will say, carry the good impression, and regarding our interpretation also, that we are not just started, we had some idea. So I think definitely your point is valid that occasionally we do like this.
And I have another question to Dr. Baldeva and Tanu both. What is the earliest age at which, and what is the latest age at which syphilitic osteomyelitis can be seen?
Syphilitic osteomyelitis, later age means?
Latest, I mean, how late can one think of entertain a diagnosis of syphilis?
That you are talking of congenital syphilis.
Yeah.
Congenital syphilis, at least I have seen 3 months old child, at least 4 or 5 patients I remember in last 8 to 10 years. And probably oldest one, age point of view, 2 to 3 years or somewhere age, I think.
So late presentation, that is, I mean, how late can it present?
Probably precisely answer, I don't know that what can be the even the optimum age for the presentation for the congenital syphilis, but at least seen up to the 2 to 3 years or so. So I'm not sure whether this is the age or beyond that can be seen. If Dr. Tanu has the answer, she can respond.
No, I don't have. I haven't.
But congenital syphilis, Vijay, at least I will say that 4 or 5 patients in last 10 years we have seen. And one patient I will diagnose in such a way that on examination of pulse, child was becoming irritable on handling. That was the point for what I asked for this, actually considered initially bone infection, turned out to be the periostitis, and then further investigations confirmed, and then mother was also having the positive test.
Thank you so much, everyone. I think I request Dr. Yashwant Rao is there. His comments and then Thanksgiving.
Chetan, one doubt. Chetan.
Yes,
Hello.
please. Yes, please.
Madam, what is the logic behind starting coamoxiclav along with metronidazole? Because coamoxiclav itself will cover the anaerobes, but the dentist has started both. Whether is it logical?
No real logic for that.
For metronidazole, he's asking.
Yeah, there is no logic.
I think, routinely, I know that some of my friends, dental surgeons, whenever they do surgery, whatever the antibiotic you give, they always offer this metronidazole because they say the anaerobic base coverage and will be with only metronidazole. So I think for us, Dr. Panari, it's all right, but they always give it. As surgeon with the intraabdominal surgery, they will give the metronidazole, whatever the antibiotic you give. So I think may not be the explanation, but yes, they give for this reason.
So if
Okay,
you're
thank you.
using amoxicillin, then you need to add metronidazole because amoxicillin will not cover the beta
But
lactamase
amoxiclav, then
in
there is no.
anaerobic.
And
But
Tanu, you said
amoxiclav is right.
the final diagnosis was Majid syndrome,
Yeah, in the third case, yes.
and this child had some skin manifestations also.
This child didn't have it at that time, but later on developed features of sweet syndrome as well, later.
Okay. Okay. Interesting.
Dr. Vijay, for your information, I think last year only there was the OSCE in the DNB exam for this Majid syndrome. That's why I remembered immediately.
Majid syndrome. But I mean,
that was the OSCE in the DNB exam.
I vaguely remembered that there are skin, manifestation in Majid syndrome.
Yes, Yashwantara sir.
Yes.
I would like to really gratitude
so madam,
Dr. Archana
why can't it be?
because she helped me in management of these two cases, the last two cases, and thanks to her and thanks to all of you. Thanks to Dr. Prajapati. Turning over to Dr. Chaitanya.
Yeah, Dr. Yashwantara.
Yeah, ma'am. Thank you all for participating in the third case of the month. And the cases were really phenomenal, bone and joint infections. First case, Ewing sarcoma, initially responding to antibiotics, and then madam was discussing why it happens. And second, Majid syndrome. Thank you all, one and all, for waiting till more than 1.5 hours for an active discussion. Thank you, one and all.
Thank you all of you and good night.
Yeah, good night. Good night.
Good night.